I do a lot of scoliosis treatment both in pediatric patients but also adults, and there's some differences. I'll explain that in a minute. I just kind of want to show you also a technique that we've developed here at Midwest Spine and Brain, which is unique, and we're now expanding this technique to other providers too. So to take a step back, this is a patient. She's a 15-year-old who has a thoracolumbar scoliosis, and this one measures about 46 degrees. And the typical treatment for this would be to go in here from the left and remove these discs. To do that, it's pretty extensive incision over here on the side, but that was a traditional technique to treat that. One way about doing the so-called anterior procedure, it does save motion segments. So if you fuse these areas here, then this part here will self-correct and you still have mobility in those levels. More recently, some physicians have advocated using the so-called posterior technique. That's also advocated by the industry. Unfortunately, that's for their bottom line. But for the patient perspective, that usually involves more levels, and then they have less levels left. Then we see these patients back 20, 30 years later as adults, and they have deterioration down there. So we advocate motion-preserving scoliosis surgery. So we've actually developed a technique. Rather than going in from the left side, we'll come in from the right side through a small incision about that big. We can address each of these discs through one small incision. And that's what we did with this young gal here. You can see not only she does have a scoliosis, but her whole trunk has been decompensated to the left side. This is this young girl now. She's a year after surgery, so there's a very, very slight curvature left. But again, we've preserved 1, 2, 3, 4 motion segments. She'd have lost 2 of those if she'd had the posterior technique done. So for Shirley's case, we actually used our adolescent scoliosis technique to an adult case. So we came in from this side here. We were able to access these discs through a small 2-inch incision. And when we did that, we would clean out these discs, put a spacer in there with a bone graft, put screws in each of these levels, and then snake a rod in there and connect it.